I'm so glad you could join us today for what promises to be an incredible and valuable, insightful session for us regarding hospice and palliative care. So, ladies and gentlemen, this is a topic that whether we like it or not, whether we realize or not, it touches us all at some point, whether as a family member, a caregiver, or simply someone planning for the future. So today we have a remarkable expert with us who has dedicated over a decade of her life ensuring families have support, guidance, and care that they need when facing some of the most challenging moments. And she has a unique ability to take what can feel like an overwhelming or a complex subject and make it approachable, relatable, and deeply human. She's worked across the spectrum of healthcare, from skilled nursing to home health, ultimately finding her true passion in hospice care. Her work isn't just about healthcare, it's about dignity, compassion, and ensuring that every individual and family feels supported at a time when they need it most. And beyond her professional expertise, she's a wife, a proud mom to two energetic kids, and someone who understands the personal side of caregiving as much as the professional. So, without further ado, it's an honor to introduce today's speaker, Crystal Smith, the Director of Admissions and Client Relations at Montgomery Hospice and Prince George's Hospice. Please give her your full attention as she guides us through this important conversation. But before we begin and I turn the mic over to her, just like to remind everyone that this is a proprietary content. All right. So we cannot reproduce the content in any way, shape, or form. Let's all welcome Crystal. Crystal, the floor is yours.
Excellent. Dexter, thank you so very much. Good morning, everyone. Thank you again, Dexter, for that warm introduction. I'm very happy to be here today representing Montgomery and Prince George's Hospice as we really dive in and talk more about the hospice benefit, talk a little bit more about palliative care, and how we really come around full circle around the patients, the family, and the caregivers. So we'll start with some of our objectives for today. Defining and identifying hospice and palliative care. And we also want to recognize and identify the differences in how both hospice and palliative care support our patients and our families who are facing life-limiting disease. So because we're going to be talking about both, I will take a pause in between to where we will hit some of those palliative care questions, and then we will have time again at the end. There is a lot of information to go over, but please, as Dexter shared, type in your questions as they come up. They may be answered later on in the presentation, but if not, we want to make sure we get to them. So we're also going to describe what services are included in the hospice benefit. Some of us come with some preconceived notions, so we want to make sure that that's fully explained. We're going to determine eligibility and the levels associated and really explore the ways that hospice care supports families and caregivers. So first, I want to start with our mission. Our mission is the root of all that we do with Montgomery and Prince George's Hospice, and that is to gentle the journey through serious illness and loss with skill and compassion. So with that, you will notice that it is woven all the way through this presentation. While palliative care and hospice are standard benefits, there are some things that Montgomery and Prince George's Hospice do uniquely. And as we're focusing and diving more into this, you will see that come to be. So palliative care. What is palliative care? Right? It's been a buzzword for quite some time. Oftentimes it's used interchangeably between hospice. It is a word that sometimes our providers use as a landing word, as a softer word when discussing serious illness and end-of-life care. But what is it really? What does it mean? Right? So palliative care is a specialized care for people who are living with a serious illness. And it focuses on providing relief from symptoms and the stress of the illness. So one thing I do want to focus on is that, or bring attention to, it is based on the needs of the patient and not on the prognosis of the patient. It's appropriate at any stage of serious illness. So it could be at the very beginning of a diagnosis of a life-limiting disease. Let's say it's COPD or congestive heart failure. At that point, there are a lot of specialists that may be coming in and it can get confusing. So it's really important to have a palliative frame of mind. It can be provided along with curative treatments, and the goal is to improve quality of life for both the patient and for the family. I do want to pause here and discuss curative treatment because it will come up again as we are talking about the hospice portion of our presentation today. When we are talking about curative treatment can be the first thing that comes to our mind, which may be a treatment like a chemotherapy or a radiation, medications that demonstrate improvement. Curative treatment is also considered hospitalizations and rehospitalizations, right? When we have a patient who has a life-limiting illness, but their goal is to still go back and forth to the hospital when there is an acute need, because they want to have that improvement and then go back home and have their quality of life. So curative treatment also includes lab work, because if we're doing lab work and different testing, we want to know what's causing an issue and we want to pursue treatment. We are very, very rarely running lab reports and doing testing without wanting to figure out what the cause is and try and intervene. Right. Curative treatment is also considered physical therapy and occupational therapy. So anything that we would do to show or demonstrate some level of improvement would be considered a curative treatment that would be incorporated in and go alongside with palliative care. So when we're understanding palliative care, it is first a skilled communication to assess the patient's preferences and goals to promote informed decision making. When we are, or when those that we are caring for are walking through serious illness, there are oftentimes specialists in addition to our primary care providers, and oftentimes confusing and conflicting information. It is also a time when there's a lot of information coming at us that we need time to process. Our physicians are usually spending 15 minutes, sometimes a half an hour with us, explaining what's going on, answering our questions. And then when we have time to process and have more questions, we may be calling the doctor's office, waiting for a few days for them to give us a call back. Not at all to speak poorly about that, but that is just the nature of how our system is set up. So when palliative care providers come in to provide care, they are really taking that time to devote to intensive family meetings and patient and family counseling. They are taking sometimes hours to sit with families, to discuss disease progression, and educate about the specific illness so that we are able to assist these patients and their caregivers and their decision makers with making the decisions that match their goals and their priorities. So they don't feel as though they're walking through this alone, but they have time to talk things through and have someone who really pulls all of the pieces together for them. So palliative care is going to be the expert management of complex emotional and physical symptoms. So some examples to think of would be the obvious of pain, but it could also be depression and anxiety, some fatigue, difficulty sleeping, and just the symptoms that come along with the disease in which someone has been diagnosed. There's going to be coordination and communication of care plans among all of the providers, right? Because again, when there is an advanced or an illness that has been identified, we're pulling in specialists, and it can get a little bit confusing and who is responsible for what. And palliative care really pulls everyone together to review and to go over that to make sure the families and the patients understand, as well as addressing the symptoms. And then this is a service that is reimbursed by Medicare Part B. So I wanted to show a quick slide that demonstrates how palliative care has really increased over the last 2 decades. Unfortunately, the most recent available is 2020, but it still paints a picture of how palliative care and the need for it has increased since the year 2000. So this is the percentage of hospitals with a palliative care program. So you can see from 2000 to 2020 how there has been a significant increase. And a palliative care program can mean anything from a physician to a nurse practitioner to a social worker. Um, all of our hospitals within the Montgomery County and Prince George's County areas have some type of palliative care program, whether it's one individual or multiple, because those conversations that we were talking about earlier take time and they take finessing. And there is a certain technique that really goes with sitting with family members to explain disease progression and help them to understand what this may look like so they can make the best decision possible and really define what they want the remainder of their life to look like with this diagnosis, identifying what's important to them. So we talked about how palliative care can be provided at the hospital, but where else can it be provided? Clinic or a physician's office, in a home setting, in an assisted living, and even some long-term care and skilled nursing facilities. With palliative care, we see that it improves quality of life and symptom burden, and it reduces symptom distress by 66%, oftentimes with improvements that last months after just the first initial consultation. Now, this is just palliative care as a whole, right? And it drives a high satisfaction and positive patient experiences. 93% of people who received palliative care are likely to recommend it to others, right? Because we have someone who is an expert who is sitting with us and explaining what is going on and giving us the power to make decisions for us or for our loved ones. So under the Montgomery Hospice Inc. umbrella, we have palliative medicine consultants. Our team consists and is primarily driven by a physician or a nurse practitioner. And we do also assist in providing social work and spiritual care support as needed. The physicians are really, again, the primary driver in our program, spending time with patients and families, doing virtual visits, and also providing visits in the clinic and in the assisted living and home settings. So we talked earlier about how this is a service that is covered by the Medicare benefit, same as it would be if you are seeing a cardiologist or your primary care. The same type of copay that would apply for that visit would apply for a visit with palliative care. We also accept, obviously, private pay and all commercial insurances. We have several clinics in our area, 3 of which are with Maryland Oncology and Hematology, one in the Silver Spring, one in the Rockville, and the one in the Laurel locations. These are not, however, strictly for oncology patients. This is just an area where we have space to provide care for those individuals who have received a life-limiting illness diagnosis and need some additional support but can come to a clinic. We also do at-home visits, as I said earlier, on a case-by-case. We see several assisted livings and then our virtual and long-term care visits as well. Are there any questions at all specific to palliative care, things that we've covered so far?
I don't see anything here, so we could proceed. Crystal, thank you.
Okay, thank you. All right, so now we're going to segue a little bit more into the hospice benefit. So we talked a lot about palliative care, the goals of care discussions, the symptom management, this overarching goals of care conversations, maybe advanced directives, this overarching theme, right? Hospice falls under this umbrella. And as you can see here on the screen, we also have hospice care kind of in this all-encompassing palliative care. So hospice care is a form of palliative care that's much more specialized. So all hospice is palliative care, but not all palliative care is hospice. So now we're going to dive into why that is. So as we're gentling the journey, you can see here with this graph or with this point here, that on the left side, we have the presentation or the diagnosis, right? At that point is when we are receiving a diagnosis, or our loved one has received a diagnosis, and we are continuing with curative and life-prolonging treatments, palliative in intent, right? But we are disease-modifying therapies, different treatments that we're doing. Our symptoms are continuing to be controlled and supported, and we're receiving that care. As the disease continues to progress, there will likely become increased needs in care. And that's, you can see by that dotted line, we are now increasing along our journey with having more symptoms, having more therapies, and maybe we're getting to a point to where that is no longer our goal. The therapy component maybe is no longer effective. It's no longer matching our goals. You know, recurrent hospitalizations may be becoming a theme. It's no longer something that our loved one is interested in, and quality of life at home is now becoming the focus as this disease has advanced. So this is when we are talking more about the hospice component and hospice eligibility. So what is hospice? It is care and services to help people live comfortably and die peacefully with dignity. It is looking at patients physically, emotionally, and spiritually. It is much more than symptom management and providing one medication. It is an all-encompassing, gentling team approach that comes alongside of the patient and the family as they are nearing the end of their lives. So earlier we were talking about palliative care and how that is, there's really no time frame for that. It can be at any stage of the disease progression, right? But hospice at its core is serving patients with a life-limiting disease, and they're eligible for hospice if their provider thinks that they have a life expectancy of 6 months or less if the disease takes its natural course. What that means is no interventions. If the disease were to progress, there would be an expectation of a prognosis of 6 months or less. Now, I will also say here, and several times throughout the remainder of this presentation, 6 months or less is the Medicare guideline and requirement, but we are all well-designed machines that all shut down differently. And even when we are looking at former President Carter, he has been on service with us for much longer than 6 months. So there are guidelines that we are looking at, again, assuming, and sometimes how I reframe this question is, would I be surprised if this patient were to die in 6 months? No, I wouldn't be, right? Or maybe I would, and they're not quite eligible yet. But if I wouldn't be surprised and the patient is on service longer than 6 months, that's okay, as long as there continues to be a decline and we're able to justify the benefit of hospice. Hospice is prioritizing comfort and quality of life through compassionate care. It's focusing on relief of a terminally ill individual's physical, emotional, and spiritual distress, symptoms during the final stages of life, and the months preceding death. And it provides an alternative to life-prolonging interventions that can cause more distress. There are times to where life-prolonging treatments are no longer as beneficial as they once were when someone is dealing with a life-limiting disease. And then quality of life comes into question, and patients and families are able to advocate for themselves and make those decisions on what quality of life means for them. And making the choice for hospice care can be one of those things that helps them with their quality of life. And they're prioritizing that over recurrent hospitalizations and really just wanting to spend time at home, wherever that may be. As I mentioned earlier, and I said it would come up several times, is that patients can live longer than 6 months. And that would mean that they could continue with hospice if the physician continues to certify that they remain eligible. And as a patient can choose to leave hospice at any time and then return again, as long as they are considered hospice eligible. So when should hospice be considered? We've talked about this, but kind of, pulling it together. When the goal of care is comfort versus curative interventions, when the burdens of a treatment really outweigh the benefits of a treatment, or when terminal illness has a prognosis of 6 months or less, right? Oftentimes, in hospice, obviously we serve in a variety of areas, but where we see the burdens of treatment outweighing benefit conversation happening the most is in the hospital setting. Um, in the hospital setting, the goal of the providers is to treat, is to fix, right? Fix the acute need and get patients back home, whatever home may look like for them. And it's really important for um, patients to have their conversations, for all of us to have conversations with our loved ones, with our decision makers. If we are providing care for people, asking them what their preferences are and what quality of life means to them, because there may be a time to where we need to advocate for our loved one on the weighing in on the benefit of a treatment. Right? In a hospital, surgeries are things that they do, treatments are things that they do, again, because that's how they're designed. But recognizing what our loved ones' goals are, what's important to them is really important so that we can also assist in identifying what would be the burden versus the benefit in many situations. So some hospice care common myths. There are so many, but I put some of our top ones here. So the first common myth is that hospice hastens death. That's not true. Hospice patients statistically actually live longer and have better quality of life. When we are at end of life and we take a step back and stop trying to treat and let the body do what the body's going to do, there is a natural relaxation that happens that allows the patients to be in a home setting without all of this testing, to be with their loved ones, to be with people who are caring for them, that really helps them have a better quality of life. I know when I first started in hospice, this was a big one. Individuals must have less than 2 weeks to live. That is still a stigma that lingers with us for a little bit, but the benefit really stipulates 6 months or less, but there really is no limit to that, as we had discussed earlier. And oftentimes it's hard to tell. We have doctors that reach out to us on a regular basis and say, hey, I'm seeing this decline in this particular patient, but I'm not sure if it reaches that 6 month. Can you all take a look? And absolutely, absolutely we can. It's always worth having a conversation. You must have a do not resuscitate order. No, one's code status is their choice. It's not the choice of the provider. What I will say is that not just under hospice, but also under palliative care, code status is something that we discuss often because it is key in the care that we're providing, and it helps us know the parameters and what it is that the patient's wishes are. It's also important to paint the picture of what that means for our patients and making sure our family members and caregivers understand what it means for someone to be a full code and what that can look like and what potential repercussions can be. So our job is to educate. The patient has the right to make their decision. Another myth, once you enroll in hospice, you cannot change your mind. That is so not true. You can. You can revoke. You can be discharged. There are people who graduate hospice. It sounds silly to say, but it's true, and we see it quite often, in which we've really shifted from continued treatments. We've come in to provide hospice care, and now that patients are no longer going back and forth to the hospital, they have a new baseline and they've graduated, but then they may come back on service a few months later and sometimes longer. So that is always a possibility. Patients also can be discharged when they move. Another common myth is that a patient needs to be homebound. Absolutely not. We are focusing on quality of life and supporting activities that promote quality of life. We do travel agreements as part of the hospice benefit. And that means that you can travel to a particular area that is outside of our hospice service area. we would connect with another hospice and they would be a contractor for 2 weeks or less. We also do transfers, much as I had mentioned earlier. The summer is peak season for that. We have patients and their families who go to the beach because it may be the last time that they take that big family vacation. Last year, we had a couple that went to Arizona. They went to Arizona for a family reunion and to see many of their family members and stay with children and grandchildren. And that's part of what we do, is support them and allowing that to happen for them and coordinating with other hospices so that that can be the case. This is not something to where someone needs to be at home and in their bed. We want to support things that are important to them and put all of the items in place that we can to make sure that we are doing that for them. Another common myth is that hospice is a place. So there is a time when it can be, but 98% of the time it is not. Hospice really is a philosophy of care. And we meet and serve patients where they are, whatever is home for them. So when is one eligible for the hospice Medicare benefit? There is a hospice physician and the primary care provider that certify the patient as a prognosis of 6 months or less. And then the patient will be reassessed for eligibility at regular intervals. So 290 days. So the first certification is saying, yes, I believe that this patient has a prognosis of 6 months or less, and that covers us for 3 months. After that 3-month mark, there's a reevaluation for an additional 3 months. After that, there is an unlimited number of 60-day reevaluations to ensure that someone is still eligible or to determine if they're still eligible for hospice. The reason it moves from 90 days to 60 days at that point is because they have then surpassed that 6-month window. There is also hospice open access for those who have insurances. They will oftentimes do carve-outs or things that are not typically covered under the hospice benefit, like curative treatments. Sometimes those insurances will authorize that in addition to hospice care, but that is something that is driven by the insurance because it is not a part of the hospice Medicare benefit. There are also exceptions that we will make because, again, quality of life is something that is significant, and we may have a short-term goal of maybe IV fluids or 2 or 3 treatments of a particular chemo so that a patient can get to their loved one's wedding or to get to their grandchild's graduation. That is something, because it is outside of the scope of hospice, that we do need to seek approval for. And it does need to very much be a short-term goal, but because we are very mission-driven and recognizing how important this is for individuals, we will be as flexible as we can in those cases. But again, it is case by case. So hospice provides 4 levels of care. And this is actually something that every hospice is required to have as their conditions of participation in the Medicare benefit. And that's really something to drive home, is that hospice is a Medicare benefit. It is something that every Medicare recipient is entitled to if they so choose. And all of the insurances follow the Medicare guidelines for eligibility and all of the other regulations that go with it. So the first level of care is the one that hospices provide the most of. That's the routine level of care. That is the intermittent care where we are coming to the patient's home, again, wherever home may be, several times a week and a month to provide care, but we are coming to the home. Respite care is really designed for those caregivers who are taking that primary responsibility of providing care for a loved one. Let's say it's a spouse. A respite would allow them to have up to 5 days, which is actually 5 overnights, so 6 days-ish, in a skilled nursing facility setting where there are RNs around the clock and it is covered under the hospice benefit. It is not an extra cost at all for the family to incur. It is part of their Medicare hospice benefit because Medicare recognizes the significance that this role it is for the spouse or for the family member, and they need a break. And this is built in to allow that. It is available for unlimited iterations, but what I will share is that when they are something that does need to happen, let's say monthly, and it's happening much more regular, that is when our team is having more conversations about maybe making alternative arrangements. Maybe an assisted living or hired caregivers is something that would be beneficial for them because they are using this respite benefit so much. Continuous care and general inpatient are very similar in nature in that there is very strict regulation and documentation and criteria that's needed to meet qualifying or to qualify for continuous care. Continuous care is when we are coming to the home for a minimum of 8 hours in a 24-hour period. It is usually, and that 24-hour period goes from 12 a.m., from midnight to midnight. So typically what we are doing is coming out in the evening and having those hours roll over. And we are in there because there are symptoms that need to be managed, and they can only be managed with an RN and an LPN and maybe a chaplain and a hospice aide in the home to get the patients comfortable. It is designed for a very short period of time, and it is very, again, specific. Once the patient is on continuous care and the symptoms become better managed, the patient will then step back into routine level of care. Then there's also the general inpatient, and this is acute management of symptoms that really are not managed well in the home setting, or maybe they're discharging from a hospital and these symptoms cannot be managed in the home to start. Some examples may be higher flow of oxygen, significant agitation. Maybe there is, they were giving IV medications at the hospital, but now we are doing a PCA pump or sublingual medications that are around the clock, and a lot that are breakthrough pain medications. Oftentimes significant wound care. So all of those are reasons as to why someone could qualify for general inpatient in an inpatient facility. So again, these 4 levels of care are things that are required for every hospice to have. Montgomery Hospice and Prince George's Hospice specifically have several general inpatient locations. 2 of which are hospital-based. One is at MedStar Montgomery Medical Center, the other at Suburban Hospital. And then, of course, we have our Casey House, which is our 14-bed freestanding community with private rooms that allows family members to stay with their loved ones when they are in this crisis scenario. So how is hospice paid for? We touched on this, a little bit. Obviously, this is a Medicare benefit. Medicare is paying for the vast majority of the patients that we are serving. There are also insurances, as I said earlier, that follow the Medicare guidelines that also cover hospice care. Active military, there are veterans benefits. Active military and NIH will oftentimes do trial participants, and that does not interfere with the hospice benefit because they are active in a trial. There is no conflict there. It's more for research. So that is something that does not interfere with payment. We also accept charity care. We are very grateful to our strong philanthropic presence and our philanthropy team that allow us to be able to provide the same level of care for those individuals who are uninsured as we do for those that are insured. Again, because service is a part of our mission and who we are, we want to make sure that anyone who needs the care is receiving it regardless of their payer status. And then, of course, self-pay. So quality of life, we've talked about through both palliative care and hospice, but this is really where we are, you can see here, right, as I'm honing in just like the picture is, where we are focusing very specifically on the details of what quality of life is for someone. And here are some examples of things that hospice addresses when it comes to quality of life. We're looking at the physical, right? Functional ability, strength and fatigue, sleep, rest, nausea, appetite, constipation, pain, the symptoms that come with the disease progression, the physical symptoms. We're looking at things from a psychological perspective, right? Assisting with anxiety, depression, things that are enjoyment, maybe fear, attention, things that bring happiness. Socially, financial burden, caregiver burden, affection, appearance, those things that are, again, important to each of us individually. And then the spiritual component, the meaning of pain, suffering, hope, redefining hope. Hope maybe at the beginning of an illness is much different than what someone hopes for closer to the end of their disease progression. Hope maybe early on for a cure, and then it's hope to make it to a loved one's event, and then it's hope for support for the family, hope for comfort, hope to be able to be outside for a period of time. Hope is something that is redefined throughout our lives, but especially on this end of life journey. And it's our job to help patients and their families redefine that. And as we are focusing on our patients and redefining it for them, it's also our role to support the families in accepting that redefining of hope. So I'm talking about all of these things that we do, and that's great, but who does it, right? Who does it? Is it just the doctor? Is it just me? Absolutely not. There is a whole team. And this is the interdisciplinary care team that is listed, but there are so many other people behind the scenes that are not listed that come around and support for this team to provide direct care for our patients and families. So at the top of our chain is going to be our medical director. Everything needs to be approved by our medical director. All of the exceptions to the rule, the plans of care. He's very involved and has other physicians that are delegated to support as well. The registered nurse. So we have RNs that serve as case managers, and they are really pulling together they're pulling together all of the caregivers to provide care for the patients. They're the ones that are typically seeing the patients the most often and educating the families. Maybe they're educating the staff in an assisted living and a skilled nursing facility on not just end of life care, but also specific things to look for this particular patient. We also have hospice aides. Our hospice aides are the eyes and ears for our nurses. They're the ones that are providing an intimate level of care, like bathing and dressing, and are connecting with patients in a way that is very unique to their role. And they are the backbone of the clinical work that we do in the home setting. And there's often times where those fears and those anxieties and those natural flowing conversations happen with our hospice aides, who are also passing on that information to the remainder of the team so that we can support as appropriate. Spiritual care, you may also see that referred to as a chaplain. It does not mean it is a particular religious affiliation. It is very important that we represent the community that we are serving. So defining spirituality and what that means to each individual. It may be a specific affiliation with a religion. It may be a spiritual experience. It could be nature. It could be music. So it's our job to identify what that is for the patient. And sometimes it's conflicting with what's important to the family. And that's also the role of our spiritual care providers to help both with this spiritual journey as they're walking this together. Our social workers, our volunteers, and our bereavement services. They are all encompassing and all come around both the patients and their families and their caregivers to really support them. When I am having conversations with family members to initiate, referrals and enrollment into hospice, that is something that I am always stressing because I can hear the emotion in their voice when they are giving us a call. And we don't take that for granted. We recognize the timing and the stress that they are under as they are making the decision to inquire more about hospice. What is this? What does this look like? Why are we here at this part? And one thing that I always really make sure to drive in on and to drive home is that Yes, the patient is the primary and the center of all that we're doing, but the patient knowing that the family member, the spouse, the child is supported and cared for is part of their quality of life as well. So we are coming around all of those people to support them as they are on this journey together. So these are some of the things that I had mentioned earlier in talking about what the hospice nurse does: medication management, symptom management, end of life education, continuing assessments. We're also ordering medical equipment and certain supplies. Medical equipment is also something that's covered in a part of the Medicare benefit. So those, maybe a hospital bed to provide ease of care, to allow the patient to sit up a little bit, to be a little elevated as they are sleeping, for the bed to lift as our caregivers are coming into the home or family members are helping to change the patient. Quality of life focus, and they're really, again, case managing the patient's care. What does a hospice social worker do? So they're providing education as well, and they're really being that supportive presence. There's maybe counseling, there's quality of life focus. Our social workers are huge advocates as family members kind of navigate the system, but also helping them maybe with placement. Maybe the home environment is not the best environment, or maybe the home environment is the best environment, but the spouse or the child or even the parent needs some additional help. So then we're reaching out, for assistance with hired help. Also grief support. And grief support, not necessarily at the end of one's life, but there's a level of grief that comes with this entire process. So our social workers are walking alongside of our patients and our families. What does the chaplain do? Again, we talked earlier, not necessarily specific to religion, but it can be. So supporting those religious conversations, celebrating life and planning those celebration of life events, active listening, helping to create rituals during this stage of someone's life, leading memorial services, funeral planning, prayer, quality of life focuses, and also connections with other clergy and congregations within the community. There are some things that are really important for family members and for patients at the end of their lives, that we may not necessarily have the resources in-house, but there are an abundant of connections that we have within the community that can support patients as they are walking this journey. I wish I had called hospice sooner. I don't know if you can see it's in quotes. Beginning of my one quote's a little backwards, but we'll let that slide. It's in quotes because we hear it more often than we would like to. I just spent a good 20 minutes talking about the benefits and all of the things that hospice does and how we come around the patients and their families. It is impossible for us to do that when patients are referred so late. We have the case managers and the social workers and the doctors and the hospice aides and the chaplains and all of the people. We haven't even touched on volunteers yet. That's a little bit further down. All of these people coming together to provide support. It is not designed to be an emergency response. And unfortunately, we are seeing, since COVID especially, we are seeing an increase in patients who are coming onto service much later and not fully reaping the benefit. And when the family members are calling us and they're being so gracious and expressing such gratitude, this is the one thing they say the most often. So there's two more things under hospice that I would like to touch on before we go ahead and take your questions. The first one is our bereavement program. Bereavement is part of the Medicare hospice benefit. When a patient passes, bereavement care is to be provided for them for or offered 13 months after they have passed. Bereavement care is not something that everyone needs or is required, but there are several touch points that happen throughout that 13-month period. It is something that is required by Medicare, but it is something that is not paid for by Medicare, which I always find interesting. So sending out a mailer that can meet the need of providing bereavement support. Here are some tips. Sorry for the loss of your loved one. And that meets the criteria, that checks the box. But again, Montgomery Hospice Incorporated, because our job is to gentle the journey through loss as well. It's really important for us to do more. So we offer phone call counseling. We have professional grief counselors and licensed social workers that are well trained and well versed in bereavement care. So we are making those phone calls. We are sending those mailers. We're also doing in-person counseling. We also have groups, workshops, grief share. Certain holidays, there are themed events, especially this time of year. Right? Our bereavement team now is really busy and underway with planning those events. They may be setting up something for children and for spouses. So, who have, those individuals who have lost their spouse but have young children, there may be a children's focus and art section for them to craft and to express their grief that way, while the spouse that is remaining is here receiving support through a grief share group. So there's a variety of ways in which we connect within the community. We also accept community referrals. Yes, our patients and their family members, those that we've served, are going to be our priority naturally. But because we are very focused and community driven, and service is at the core of what we do, we are also a support for our community at large. There have been businesses that have reached out asking for additional support. Maybe a law office to where an attorney had passed. And how do we do this? Do we touch his office? When is it appropriate to touch his office? You know, Mr. Jim hasn't cried or showed any type of emotion, and I'm a hysterical mess. Is this normal? So we go out and we support and walk people through, a time to remember. Let's reflect and remember this individual's life that has impacted you all so much. And let's talk about grief and how it looks different for everyone. And here are some tips and some things that you can use. Our facility partners, our agency partners, within the community that have suffered significant loss, maybe amongst their staff, or there are just a good number of residents or customers that they've been caring for that have passed. And it's a heavy hit, and we want to walk through that with you. So we will always welcome a phone call for some way that we can support, even if it's sending you something and a few bullet points and tips and tricks. We do want to come alongside and be a support. So our volunteer services program. So volunteer services and complementary therapies really go hand in hand. Again, Medicare requires that we offer volunteer services. And we are very fortunate to have a large program with comprehensive training. We honor veterans as a part of our volunteer services, as well as complementary therapies. So while complementary therapies falls under volunteers, we also have 3 aromatherapy nurses that are on staff with us. Aromatherapy is something very unique that I get excited about when I talk about it. When I first started with Montgomery Hospice, it was not something that um, was really very significant. I was very reluctant and apprehensive about that idea, but seeing it applied to patients and to their families, watching the value that a lavender hand oil and massage can provide for not just the patient to help them relax, but also for that family member or that caregiver who is stressed in the care that they're providing, just to help the senses. Other comfort touch, music therapy, massage, and animal companionship. Those are just some of the additional services that we offer under complementary therapies. And I was also corrected very early on when I started, because I referred to them as complementary because, hey, they're a free service. But there's so much more than that. They are complementary because they come alongside of the other services that we are providing, to really support the patients and the families and the caregivers. It's so much more than just medication and medication management. What else can we do to help someone relax, or to maybe relieve odor and to have dignity at the end of their life? So I want to touch a little bit more about our volunteer services. So our volunteers founded Montgomery Hospice in 1981, and they have really continued to be and play an integral part in our organization. And Medicare mandates that not only the volunteer services are available to all, but they must equal 5% of all patient care service hours. So again, Medicare has these regulations, and this is something that is required for all hospices as conditions of participation. Our volunteers work in 3 primary places. There are several secondary places and other duties as assigned, or as volunteered, I would say, other duties as volunteered. But primarily, our volunteers are in patients' homes, in assisted livings, and then in our acute inpatient care facility, Casey House. We also talked about other areas where they can help, sometimes with fundraising and special events, administrative, but patient care and complementary therapies and Casey House and even bereavement are all going to be the big ones. We Honor Veterans is also something that I like to highlight under our volunteer program. It's a program of the National Hospice and Palliative Care Organization, and it's in collaboration with the VA, and it recognizes the unique needs of our veterans and their families, and how we can care for them, how we can honor them, and especially at end of life. It's very important for the patients we're serving, but especially for their families and for their caregivers. As they've heard the stories, maybe they've been with them on their journey as they have served. And it's really a moment to honor them as they are reaching this point in their end of life. We also have pinning ceremonies to where we will have representatives from and volunteers from the shared branch of military to come in and honor them with this pinning ceremony. And they will receive a pin, a certificate of recognition, and a star from a retired, military personnel, and the American flag and the fleece blanket. So here I have some photos of some ceremonies that have happened where they allowed us to share their photos, and you can see the blankets that have been made by our volunteers and the pinnings that we have done, and it really just, it's a way for us to honor. An example of the blanket and the certificate. And look at all those volunteers in the background making those blankets. This young guy here smiling, excited for the service that they're doing, but service is at the core of who we are, from the very top all the way through, and even to our volunteers who are volunteering their time. So that concludes my Hospice 101 presentation. It's a lot of information, I recognize. So if there are any questions, there may have been some things that I missed because there just is so much to it. So I'm happy to answer any questions.
That is so beautiful, Crystal. So yes, I got a few questions for you.
Okay.
And all right. Let me see. Okay. Do patients need a doctor's order for palliative care? Just if you've just in case you've already discussed this, well, this will just serve as a reiteration. So yeah, that's the
No, that's a
question
great
here.
question. That's a great question. Yes, there is a physician order that is needed for palliative care. One thing that I
Mm-hmm.
do very much encourage individuals on, though, is that palliative care has been this buzzword, but not every provider fully understands what it does. So it's important to know that you are your loved one or you are your patient's advocate. So if there has been a diagnosis of a life-limiting disease, reach out to the primary care, reach out to the specialist and say you would like a referral for palliative care. They are not going to replace the providers that are in providing care, but they will consult and pull everything together. But you always have the ability to advocate for that. And you can also reach out to us and we can assist you with that.
Mm-hmm. Okay. Next question is, can you please define hospice eligible?
Yes. So hospice eligible is going to be someone who has a serious disease or illness with a prognosis of less than 6 months. Now,
Mm-hmm.
Medicare also gives us what we refer to as LCD criteria. So The top hospice diagnoses may be like COPD and congestive heart failure, senile degeneration of the brain, which would fall in line with dementia and Alzheimer's disease, cancers. But then there are other diagnoses to where there may be multiple things that are significant at play, and there's not a specific defined diagnosis we can use. But because there are enough things going on, we can say that this patient's prognosis would be less than 6 months. But the reason I'm mentioning all of those diagnoses is because each of those have certain criteria as defined by Medicare on what would make eligibility for someone with CHF, on someone with cancer, and different types of cancers. What I will say in addition to that is if there's ever any question about it, regardless of where someone is in their disease progression, you can always reach out. Hospice is not something that you need a physician's order for, because we have physicians that can certify eligibility and move it forward. It's always great to obviously have a conversation with one's provider, but you do not need a prescription or an order to make a phone call for information. So we can ask those questions about what's going on and help you really see where they are in the disease progression state.
Mhm.
I hope that answered
Okay.
it. If not, please chime back in.
Okay, here's an interesting question. Do you
Okay.
have resources or tips for rehoming pets after the client has passed?
Say that again.
Do you have resources or tips for rehoming pets after the client has passed?
For rehoming pets,
Yep.
I don't, but I may know somebody who does. Is that something that I can send to you and then we can send out? Or I don't know if we want them to drop their information in the chat and we can set something. I have a few people that I would want to reach out to for that, because I've seen conversations that have happened around that. So I'm sure that there are some resources outside of the SPCA.
Sounds great. So anyway, usually we, email them
Okay,
after, just let me know what message you want to pass along. We'll
absolutely.
just add
I'll
that
get
in
that
the
to you.
email. Yeah.
Yeah, you got it.
Okay. All right.
Great question though.
Beautiful.
Showing love for
Beautiful.
the pets. Yes.
Mm-hmm. Mm-hmm.
They're family
Okay.
too. So yes.
Mm-hmm. True. True. So Brian is asking about the difference of palliative and hospice. So I'll just answer that because he mentioned here that he can go back. So yes, that was discussed, and you can go back once we have, the replay out. Is that okay? Yeah.
Yeah,
Okay.
I'm
Well.
if I have time, I can elaborate on it again real quick. It's that's fine. Oh, was that a thumbs up from him? Okay. Okay.
Okay. So
Okay.
here's from Renia. Can
Uh-huh.
patients stay on all of their current medications with palliative care?
Yes.
Mm-hmm.
Yes, if they so
Okay.
choose. So palliative care is really going to help the individual understand the burden and the benefit of those medications, and understand the role that they play. And there may be a time very early on that all of these medications are serving the patient. But as disease progresses, some of those medications are no longer serving the way that they were. If anything, they start to cause more side effects and symptoms that then additional medications need to be added to circumvent those symptoms. So that's why palliative care is so important, to help the individual navigate all of that and make the decision that's best for them.
Thank you all so much for joining us today for this insightful session on hospice and palliative care. And a big thank you to you, Crystal, for sharing your expertise and helping us better understand how the services can make a meaningful difference in the lives of our families and caregivers. And before we finally wrap up, I'd like to invite you to join us once again for our next coffee chat on the third Wednesday of the next month, as we always do. And we'll have another fantastic guest and valuable discussion lined up for you. So be sure to mark your calendars. Um, stay tuned. watch out in your inbox. We'll be sending the invitation to you as well. So we hope you found today's session helpful, and we look forward to seeing you once again. Have a wonderful rest of the day.
Thank you, everyone.
See ya.
Bye.
Bye bye.
Visiting Angels, we're committed to enriching the lives of elders and their significant others. Our monthly coffee chat sessions aim to make your lives easier and better by providing quality information from our expert panelists. We're here to elevate your quality of life, offer practical wisdom, and ensure you have access to valuable insights. See you again next third Wednesday of the month.